Hello, and welcome to our webinar on how to maximize revenue cycle in a post-COVID environment. Israel Rosenberg, Vice President, is the strategic leader of Comprehensive AR Solutions Business Development and Client Relations, leading that team. After graduating with a bachelor's degree from FDU University, Israel joined the team at Comprehensive, working his way up to supervisor, manager, director, and ultimately partner. Israel is an active member in his community and is the president and treasurer of a local nonprofit, giving back to the community. We're looking forward to his presentation today, and so it's my pleasure to pass the baton to Israel.
Hello, everybody. Thank you so much for the intro, Meredith. My name is Israel Rosenberg, Vice President of Comprehensive AR Solutions, and we are a revenue cycle management company. So prepared a nice presentation today, PowerPoint presentation about some challenges that exist in the revenue cycle management landscape in a post-COVID environment. And that's really what this presentation and PowerPoint will aim to achieve, is to attempt to bring to light some of the various challenges that exist that providers are faced with when it comes to revenue cycle management. So just to start out, COVID was obviously a world when it first hit. The first waves were starting to hit. It was a world of care concerns that were very much in crisis mode. Care concerns, crises, making sure that patients in skilled nursing facilities were being attended to and cared for in a way that was the most effective. And that was priority number one. I think we can say that, you know, the financial challenges or the non-direct care concerns were secondary to anything else. As we emerge from that post-COVID crisis, we're seeing a landscape in revenue cycle that has also become increasingly more challenging. So what we've compiled for today's presentation is a combination of talking points, data points, and statistics from various reliable sources, as well as some stats and data within our own operation as a provider of revenue cycle management services, and with the goal of taking that data to illustrate or to attempt to illustrate the various different challenges that exist as it relates to revenue cycle management. So without any further ado, I'll begin the presentation. As I mentioned, initial post-COVID challenges was a true healthcare scare, right? There was real care concerns and real healthcare concerns. A combination of working from home, staff unable to physically come to workplaces, hybrid schedules, and also substantial supply chain issues. All of that was, you know, care related and substantially so. As the crisis somewhat calmed down, you know, there was a new crisis which began to emerge, which I'll call the staffing crisis. Staffing. I think every provider of healthcare services can relate to that challenge today, and that's obviously something that's real. Here are some stats that we compiled from a couple of various different surveys. Over 1 in 5 American workers got a new job last year. So for the year, this is actually a 2023 survey. So for the year 2022, there was more than 1 in 5 workers got a new job. Now, again, assuming the audience that I'm talking to has a lot of experience with dealing with these challenges, or at least exposure to some of these occurrences, aside from, you know, I think when it comes to, you know, American workers changing jobs, I think there's two things that need to be taken into consideration, which exist in a care world, and again in a revenue cycle. You know, this will be very tunnel vision to what the revenue cycle concern is. If you could just flip back for a second, Melanie, I'm sorry. You know, talking specifically to the revenue cycle concern in specific, there's two issues. One is, hey, somebody resigned or somebody took a new job. I don't have staff, right? But then a compounded issue, and I'm going to use that terminology a lot today because a lot of these issues are compounded, right? It's almost like it's like a double whammy. There's the issue that you don't have staff, and then okay, when you do fill that seat, very often it's filling that seat with somebody that's inexperienced, and it presents a whole new challenge of, okay, how can I get that individual up to speed with to be an expert on what they need to know or about how we operate as soon as possible. So there's a vacancy, which is a challenge of filling that vacancy, and then okay, once I have somebody, how fast can he or she be productive at a high level? Another statistic, which is a pretty shocking statistic, is that 56% of workers are going to be looking for a new job within the next 12 months. Again, all highlighting the enormity of the staffing challenges that exist in today's landscape. If you can go to the next slide, Melanie. So as it relates to revenue cycle, who is this affecting in the revenue cycle management space? It's affecting staffing at the payers. And when I say payers, I'm talking about the providers and the payer sources that are providing payment to providers, whether it's skilled nursing facility providers, assisted living facility providers, clinics, doctors' offices, whoever it may be. Staffing at the HMOs, at the insurance companies, is real. And when you look at it, we're all facing challenges in staffing. Well, the insurance companies are being faced with the same thing, and that presents itself with a multitude of different challenges, which we'll elaborate. Medicare is one of the main payment sources for providers across the nation. Staffing at the Medicare payer has changed also. A little bit easier on the Medicare side, and again, we'll get into the detail of it as we move through this presentation, because Medicare, for the most part, is very heavy on automation, which is a good thing because they're much less staff intensive and staff reliant than pretty much all the leading insurance companies in the nation are. But that being said, you do need humans to process issues that may come up. As much data as they have and as much automation as they have, there's somebody on the back end that may need to push through something on the back end every so often. So obviously that presents itself with challenges as well. Medi-Cal social services offices, the Medicaid eligibility departments are being faced with the same thing. That can result in a delay in Medicaid applications, a delay in processing Medicaid applications, a delay in making decisions or determinations for Medicaid applications. And by the way, there's a federal mandate which has existed for a very long time that Medicaid, Social Security, and eligibility determination offices are required to make decisions within 45 days of an application. We service facilities in various different states, and I think that same stays true for California. For the most part, that's probably not happening. But again, it's compounded today because of the staffing challenges. Social Security offices, Social Security Administration is also being faced with staffing challenges. How does that pertain to, or how does that affect a nursing home provider? A big part of a payment stream for skilled nursing facilities across the country is the income responsibility that patients need to pay to facilities as part of their Medicaid obligation. And in many instances, the facilities will have to have communication with the Social Security Administration, whether they're seeking to become the payee or whatever it may be. And staffing delays at the Social Security Administration have been real as well. So let's get into a little bit of detail as to what the effects are for staffing challenges at the payers. And again, I think a big chunk of this presentation is really about raising awareness. I would love to say that I can provide or advise practical solutions that relate to everybody on this call today within the time frame that we're allotted, but that's probably not possible. We might have to do a follow-up for that. But I think step number one is recognizing what the challenges are and trying to say, okay, now I know what I need to do. And the how-to is step number two, but at least we have a roadmap of okay, here's the challenges, here's what I think we need to do to be able to overcome them. And then how to do that is obviously a whole separate conversation. So payers have high turnover, which leads to mistakes or delays in the cycle, and it's compounding the challenge. So let's talk about the challenges and how those challenges sometimes become compounded depending on the scenario that we're talking about. So This portion of it will be very heavily focused on insurances and managed cares, which is again, a big payment source for providers across the nation in every state. Obtaining initial HMO authorizations in a timely manner. Managed cares, generally, I would say 99% of the time, so more than generally, almost always require an authorization in order to pay a claim. Again, in many instances, those authorizations are manual. There are some insurance companies that have an automated process for it, but many insurance companies that don't. And you got to get a rep on the other side that's looking at the care and that's providing an authorization. All the while, you have a hospital that's looking to discharge a patient, or you may have a patient in your facility that you want to know whether or not they'll continue to get coverage, or does your social services department need to plan for a discharge? And getting that HMO authorization in a timely manner has been a challenge. Again, without an authorization, for the most part, the insurance companies will not pay claims. As some of you may know, getting a retroactive authorization is something that many insurance companies will not provide easily. I would say most insurance companies will not provide easily, and in some instances, they won't provide it at all. So again, that's a significant challenge because I'm being challenged with getting it timely, but I know that I'm going to have a problem later down the line if I don't get it. And that exists with an initial authorization or the second bullet, which is getting authorizations updated after receiving an initial HMO authorization. So insurance companies generally will not provide an authorization for the entire length of stay. They'll give you a couple of days to start and they'll request updates. Well, what do you do if the insurance company isn't providing those updates as quickly as you need them? Now, bullet number 3 talks to the second point of the staffing challenge that I initially started out with, right? There's one is the empty seat and filling the void, and then number 2 is, okay, filling the void. Who's sitting in that seat, and what do they know about our process? Every insurance company has a different way of how they issue authorizations. They have different revenue codes which vary per contract. There's extensive knowledge that is needed for somebody on the insurance side to be able to give an authorization that talks to the contract of the provider that'll equate to payment. So in many instances, we found we're getting reps on the insurance side who are providing authorizations, but they're giving it inaccurately. Now that can mean they're not keying in the proper coding that they need to on the insurance side, which will then lead to denial of payment. That could mean that they're giving an authorization for an incorrect amount of units that are needed. Again, it could be a variety of different challenges, but all challenges that exist because of a general staffing challenge and a staffing challenge of how trained in is the individual that we're talking to. And again, this exists in pretty much in every industry, I think. And it's not to say that the insurances are challenged any more than any one of us are, but again, it presents a significant challenge, all which may relate to unpaid claims, which very often mean uncollectible debt. Item number 4, claims being submitted according to contract requirements, and the HMOs in turn denying claims incorrectly. Again, I put this in parentheses, a lack of trained and staff. We have stats later on in this presentation, which prove the ratio of denied claims are going up. But again, you can have a provider that's submitting a claim exactly the way they should be, and those claims are getting denied for invalid reasons, which in many times the insurance companies cannot clarify themselves because there is an inefficiency or inconsistency in how it was being done in the first place by the representative at the insurance side. Again, all a result of a lack or inadequacy of trained and staff that know how to deal with keying in claims properly. Second challenge, TAT, which is a revenue cycle terminology for turnaround time. So turnaround time for payment on appeal claims is generally longer, and that's magnified by a higher ratio of denied claims to begin with. So again, we're talking about compounded challenges, and I think everything's a domino effect. So, we spoke about the compounded challenges of lack of trained and staff. As it relates to RCM, as again, many on this presentation may be aware of, getting paid on a denied claim, which you need to appeal, is generally a longer process. Again, insurances do have automation. If they're reading the claims properly on their claims database, they're going to pay that claim timely. And that's generally a pretty fast turnaround time. When it gets stuck in denial phase, you need to talk to a human to get that reversed, which is automatically going to be a longer process. Even before the post-COVID challenges, getting paid on a denied claim was a significantly longer process than getting paid on a clean claim to start. So you have a claim that's clean that is getting rejected for various different reasons. Now you have an appealed claim that's going to be taking even longer than it has pre-COVID, because of the fact that, again, you have people on the other side who may or may not know how to process these claims correctly. They got to escalate it to their supervisors. Their supervisors are overloaded with an increased amount of denied claims that they're faced with, because of the fact that many representatives cannot process these claims properly. So we're dealing with a higher ratio of denied claims, which leads to an appeal process which is longer. And again, it's even longer today because of an inadequacy of trained staff. Again, compounding the challenge is valid appeal of claims sitting in the queue. We're appealing claims all the time, and sometimes there's a really valid reason to appeal, and it should turn into payment relatively quickly. Again, there's humans processing it, and it's a queue that's a much longer queue than historical. Claims denials based on inconsistent codes, which is again a result of new staff, and upon calling on insurance companies, reps are unable to clarify. This is a real issue and something that we're faced with on a day-to-day. You have codes that are being put in, which is not according to the contract. You call the insurance company, you say, hey, let's talk about this claim, and they're unable to give you an answer because they don't understand what was being put in the first place. Again, compounding the issue and causing for longer wait times. Let's go to the next slide, Melanie. Okay, so effects of challenging staffing at the payers continued. HMO contacts and provider relations representative challenges, and the second bullet really elaborates on that. Claims projects can have months of work done on both sides, and the process may need to start over because of provider relations staffing adjustments or changes. So as again, getting a little bit technical on the RCM side, generally speaking, when there's a project of some sort, for whatever reason, you have an insurance company that denied a high ratio of claims, and again, this happened pre-COVID as well. There are times where the insurance company will say, okay, here's a designated provider relations rep that will work with your issues as a project, and it's generally not done when there's a singular case. It's only when there's a bulk issue that occurs, which again is happening more frequently. And you need again, provider relations reps are generally the more experienced reps on the insurance sides that understand the real nuances and the back and forths of how the insurance claims process works. And they're here to be able to, or they're designated by the insurance companies to be a representative for the facility to resolve issues. We've had this on many occasions where we're submitting projects and there's back and forths, right? It's extensive, detailed spreadsheets. There could be various different reason codes that correlate to various different claims on those spreadsheets. And there's a lot of back and forth that's needed to be able to clarify the various different scenarios. So we'll have a back and forth, a project that runs, we're 90 days in, and the next month, comes a time for an update to the provider relations rep. And guess what? We have a new provider relations rep to deal with, who then needs to get acclimated with the back and forth, understand the story, get themselves familiar with what the historical 90 days of conversation was, which only prolongs things even further. And something that is just a general issue is that insurance companies generally, as time goes on, there's just a less of a willingness to want to discuss a claim or deal with the claim. If you go to an insurance company and say, hey, I want to talk about a 2-year-old claim, they may tell you our books are closed. There's nothing to do about it. So there's an issue with the projects being delayed, but also kind of running against the time clock to be able to say, we need to make sure that we're doing it in a way where it doesn't get too old or too stale for the insurance company to want to deal with it. Again, the end result, I think, in all these scenarios very often is unpaid debt and unpaid claims, which obviously may have a significant financial impact on any provider. This issue is impacting veteran administration claims for those providers out there that have a contract with the veteran with the VA. Not all that popular, but it exists. And again, they're similar, right? It's also kind of like an insurance company. Medicare claims too. Again, we spoke a little bit about it in the beginning. Not as much of an issue, but it's an issue, or presents challenges, I should say. Another item to bring to the table is a potential data processing error, which may trigger an audit. And again, for many of you on this call, you may or may not have seen increasing audits come to your facility based on insurances looking at clinical documentation or potentially doing takebacks. Again, it's all about how the claims are keyed in, how the claims are being keyed in, what's being checked off on the insurance's database. If there's incorrect items being keyed in, which is a frequent occurrence, it could trigger takebacks. So again, you can have a claim that you worked a year to get paid on, and only to get inaccurately taken back a year later, and now you're trying to talk to an insurance company about a 2-year-old claim, which is difficult, and sometimes a mountain that is insurmountable. Again, we spoke briefly about the Department of Social Services offices, lack of staff to approve Medicaid applications, Medi-Cal applications, Social Security Administration or pension income obligations. Again, to this day, we're still seeing some Social Security offices that are not fully open and staffed, which causes delays in representative pay applications being processed. Again, all items that really tie into the bottom line of a provider if these are resulting in either unpayment, either lack of payment, or a delay in payment. Let's move to the next slide. So these challenges have made the revenue cycle more cumbersome in 2 ways. Just to summarize, right? One is that there's more time needed to fix the issue, because generally speaking, fixing a problem is more time consuming and cumbersome than getting it right the first time. So you may have had a project, a claim that took your biller an hour to get paid on, 3 years ago. Today, it's taking 3 hours to get paid on that claim, if we combine the amount of work that's going in, and that's just one claim. So item number 2 is not only is more time needed, but it also requires more skilled work, right? So again, fixing a challenge is harder and more cumbersome and more time consuming. So this is like a real compounded issue, right? We're dealing with staffing issues in the first place. We now have an increase in workload, right? Which even before the staffing issues, we would need to have added staff. Now we find that we need more staff, but also less workers. What do we do? And not only that, you also need more skilled work. And many providers are seeing that today, where their billers or finance teams that were really successful and efficient at their job 10 years ago are being challenged today. And the reason is because there's significantly more challenges that billers and AR employees are being dealt with are dealing with today. So it can affect seasoned staff, but definitely can affect new staff, right? How am I going to get somebody that just filled a seat in my finance team to be able to get up to speed on not only billing and revenue cycle, which is a very tedious and cumbersome and potentially challenging process, but how can I get them to be up to speed to work on projects that are something that somebody may need to be seasoned for 2-3 years plus on, and again, that's a real issue, especially that's magnified in today's staffing landscape. So while the nation grapples with adequate staffing ratios, the challenges at the payer side has compounded the staffing issue in 2 ways, right? Just to summarize, one is that more staff hours are needed, and the second thing is the need for highly skilled staff is something that exists today more than it has historically, both of which are challenges that providers struggle with, especially in today's staffing environment. Let's move on to that. Thank you. So, there's takeaway questions that are presented here. And again, I think that these are really helpful, talking points, and the goal is to present issues so that providers can potentially reevaluate their measuring stick, so to speak. And as a provider, I think that there's real questions that you may need to ask yourself, right? Estimate the amount of new denied claims that your finance staff had on a monthly basis 3 years ago versus today. Again, depending on what the finance office or the billing office in your respective facilities may look like. it's something that you can pull for your team and try so they can try to get some stats on how many more denied claims do you have today than you did historically. And as a provider, I use staff to deal with this influx, right? So, I've especially in the past couple of years, I've spoken to many providers that are challenged with revenue cycle and collecting at a high level. And my first question is, do you have enough staff, right? What's your head to bed count ratio of the amount of staff that are doing your billing versus the amount of beds that you have, or the revenue that you're producing? And you may need to reevaluate um, what your ratios are, right? Um, Again, question number 2 is estimate the amount of new takebacks on claims that your finance staff had on an annual basis 3 years ago versus today. That might be significantly more. And again, as a provider, I use staff to deal with this influx. It's not fighting a takeback is manual labor. It's cumbersome. It's not just keying in codes on a computer. Do you have enough staff hours in your organization that can support these type of tasks and challenges? And again, we'll get to it in a little bit, but nationwide, the appeal ratio is very low, and I think that a lot of it has to do with the difficulty in the work and whether or not providers are simply staffed well enough to be able to appeal every claim that gets denied. So historical metrics, sorry, just want to, if you can, yeah, historical metrics and best practices may need to be reevaluated and determine if feasible to align with new needs, right? You knew what your metrics are, 5, 10 years ago. I need one biller for every, for this amount of revenue. And these are things that are real talking points and real questions that you may need to reevaluate. The metrics and the ratios that I used to use, are those something that are adequate and realistic in today's environment? And in many scenarios, the answer is no. Let's move on. So in addition to HMO cycle delays, data shows that there are more insurance claims to contend with versus fee-for-service model. We spoke about the Medicare versus Medicare Advantage challenge, and nationwide stats, and again, on a state level, it varies, but every state has seen an increase, and it really pins down to a county level as well. And we have stats on really nationwide stats on a county by county basis, what that managed care penetration looks like on a county by county level. So again, this is a global talking point, but also may need to be evaluated on a case by case depending where your facility is. But in 2023, the Medicare Advantage penetration was at 51%, which means that 51% of Medicare beneficiaries are enrolled in a Medicare Advantage plan nationwide. Denial rates. What do denial rates look like? We spoke about the fact that they're increasing. This is, this is what we see in our organization, but what do the stats say? And again, based on studies that we've done, there's an uptick of 20% in 2023 versus 2022, and that brings the total denial rate up to 49%. So 49% of claims nationwide are getting denied. A staggering 1 in 500 are getting appealed. And that's something that's, I think, a pretty shocking number. I think, again, it highlights the complexity in appealing a claim. It highlights the tediousness and how labor intensive it is. But think about it. If you're only appealing 1 in 500 claims, that means you have 499 claims are going to go unpaid. Now, sometimes it's a matter of, is the amount of the claim that I'm appealing worth it for my staff, right? If you have a claim of $100 that's going to take, 10, 15 hours to appeal, you might make a decision as a company to say, okay, I'm not going to pursue that. And I think that some of that is in the stat. But again, it's a staggering number. Post-pay takebacks have increased in 2023 to 2.4%. So not a tremendous amount, but it can be a lot of revenue. Let's move on to the next slide. This is a trend of Medicare Advantage penetration on a year-by-year basis nationwide. Okay, so in 2007, there was a 19% penetration rate. 2023, we jumped up to 51%. Well more than doubled over, in the past few years. So again, even without the current staffing landscape, us as a company, we made a decision in 2010 to significantly ramp up our staff to revenue ratio because we see that there's a need there's a larger staffing need for HMO claims versus Medicare claims. And again, as you see those stats increasing, it just means that you need more and more staff to be able to deal with the same amount of revenue. Let's move on to the next slide. So again, appropriate staffing ratios, and these are some pretty phenomenal stats. I actually was really shocked to see it myself. I told our team to pull together some data for what staffing in our team looks like. Based on staffing ratios in our organization, managed care claims require 6 times more staff than traditional fee-for-service. So for every $1 that's needed for every $1 on Medicare, you need 6 more people to collect $1 from your HMO. Again, not one, we're talking about hundreds of thousands, but the same amount of revenue, right? The claim amounts are the same. You have a $10,000 claim for Medicare and a $10,000 claim for managed care, but you need 6 more heads to collect the same amount of revenue than you do for Medicare. So again, as we look at increased penetration in managed care, without COVID staffing issues or staffing challenges that we deal with, you're inherently going to need more staff as managed care penetration increases, right? And that's a question that I think providers need to ask themselves. Hey, again, we had 2 billers in our team 5 years ago. Are we staffed for 2 billers to be able to tackle the AR that exists today and the revenue that exists today? And again, in many scenarios, the answer may be no. That was the answer for us internally as an organization. We had to significantly ramp up the staffing once the managed care penetration became real. But again, talk about compounding issues, right? You have more of a need for staffing because there's more insurances to contend with, and also, again, the overall staffing issues as a whole. So as a provider, are you staffed to deal with the increase in managed care penetration? If you're staffing 1-to-1, you very likely may need to reevaluate whether or not that's a healthy ratio. Let's talk about stats as it relates to the uptick in denials. Again, I spoke about it, but let's look at what the statistics say. So a recent KFF study on Affordable Care Act insurance plans found that for 2021, plans denied on average 17% of claims. One insurer denied 49% of claims, and overall insurance denials range from 2% to 49%. Again, depending on the insurance company. In 2022, a January 2023 report by Health Leaders magazine states that denial rates increased by 8% in 2022 versus 2023. We as an organization have yet to see a report for 2023. It's too soon to tell. I mean, insurances are still processing many 2023 claims, but we can clearly see an increase in denials from HMOs in 2023 versus 2022. Let's move on to the next slide. So appeal rates are an extremely low ratio, which we discussed. Let's look at, the source of the information. Healthcare.gov data shows that nationwide appeal ratios are only once in every 500 cases, which is 0.2%. And that's, again, a number that I was shocked to see. So these are just some graphs of what we see from healthcare.gov, denying 70% of in-network claims for 2021, right? How many claims paid? 243.3 million versus 48.3 million that were denied. And again, the appeal ratios are just astounding. Denied claims not appealed, and this is data that the insurances are reporting, north of 48 million versus only 90,000 and change of denied claims that were appealed. And we're talking about first level appeals to the insurer. We're not even talking about to the provider. We're not even talking about second or third level appeals, which are even more cumbersome, right? Because not every appeal gets overturned. Let's move on to the next slide. Okay, takebacks. So ADR, which is additional documentation review and post-pay audits. Medicare has a 5-claim probe ADR, which is still ongoing. Again, as a provider, I'm sure you're well aware of what that means and what that means for your organization. Again, more staff needed to scrub things on the front end in many cases. Many insurances have increased post-pay audit ratios, resulting in increased takebacks, oftentimes unsubstantiated but lengthy project to fix, which is something that I think we covered earlier on. But just highlighting the fact that fixing it takes a lot more time than getting it right the first time. A January 2023 American Association report cites that payer takebacks cost physicians and hospitals utilizing their platform more than 1.6 billion each month. And again, it's an astounding number. And they involve the takebacks of previous payments up 29% from the year prior. So and the last thing is that ADRs require clinical reviews and evaluation, which is not only a potential cash flow issue, but may lead to challenges with adequate staff to appeal. So, we spoke a lot about your billing and finance staff, but what does your clinical staff look like? Do you have enough clinical staff to be able to fight these additional documentation review appeals? And that's something that's a real question for providers as well. We're seeing many providers choose to outsource a lot of their clinical functions for that reason. So how do we mitigate these challenges, right? We spoke about the challenges, and I think, again, this is not about what the road looks like, but just, well, not, it's what the road looks like, but not necessarily the direction on how to cross that road, right? But well-trained and skilled staff is number one. And as a provider, the need for well-trained and skilled, experienced revenue cycle staff is important now more than it ever has been. This begins with identifying adequate staffing needs, right? Not only do you need skilled staff, but you also need to understand and recognize what your ratios need to look like. Staffing challenges are commonplace, but the industry hasn't provided much guidance on how to best position finance offices for success. We hear about people, we hear all sorts of various different challenges on staffing. I'm doing this presentation today, but I think that there's been a very limited amount of guidance and education that's been given to providers about, okay, how do you need to restructure your finance team? And understanding what your staffing needs are is key. And I think step number one, before you say, okay, I'm going to go and get staff, how many staff do you need? Understanding end of the line needs will help you strategize, right? So, and that ties into that road that I was talking about, right? What does the end of the road look like or need to look like? And then, okay, how do we get there? So identify and hiring the appropriate staffing ratio needed per census count is critical, and it extremely critical, and I can't highlight that enough. So in summary, the insurance landscape continues to be more challenging year over year, and it's something that providers need to really understand and recognize and say, okay, how am I gonna tackle this challenge? Let's move on to the next slide. Again, on the topic of staffing, there's staffing on the facility level, and there's also staffing on the business office level, right? On the facility level, you have admission changes, you have business office manager changes, you have case management changes, and each case has an effect because it's a flow, right? Your admissions team is bringing the patient in, and then it's a continuity of care and various different hands in the pot that need to make it successful, need to make it a successful revenue cycle stream and revenue cycle process. Turnover oftentimes disrupts that continuation and that story, right? You have new staff. How are the cases being handed over? Are they being handed over properly? That's something that's a real issue. Staffing at the billing offices, delays in AR processing, which we discussed on the insurance side, lack of clarity and confusion on more complex issues, which is a real thing because again, I shouldn't say every, but so many finance offices are challenged with that, right? What does this issue mean? The insurance company telling me this, what does that mean? And then again, confusion on the back and forth between the finance team and the facility operations team, which is again compounded by potential turnover. Let's move on to the next slide. We have found for our clients that administrative and corporate support is needed now more than ever. We believe that administrators or somebody higher level should be overseeing the business office managers and ensuring accountability in this department. Addressing the items discussed on the to-do list to make sure that they're completed in a timely manner to close the gap in non-payment. And general areas, but not limited to, obviously, I think that's a laundry list. Cases missing insurance authorization. Medi-Cal pending cases without asset verification that can lead to denied Medicaid applications too, which obviously result in lack of payment. Estimated incomes without income amounts or direct deposit or non-payment. And private pay paying patients who may be non-paying, non-responsive, or in a penalty period due to a transfer of assets. And these are all issues that generally need a lot of oversight and problem solving. And we're finding that corporate support is needed now more than ever. Doing the aging reviews, it's tedious, it's detailed, it's complex. Looking line by line and patient by patient can be something that's very challenging. And trust me, I know all about it, but it's something that we find is needed to be able to handhold and to be able to give guidance. Enforce the methods of being proactive, um, obtaining direct deposit on admission if possible, submitting that application to the Medi-Cal department as early as possible, potentially working on HMO copay collection upon admission. These are all things that are practical application tips on being proactive, and these things will vary and range based on your facility and what you're being challenged with. But the goal is identifying it and trying to fix it early in the game will generally solve a lot of headache later down the line. You don't want to be talking about a problem 3 months after the cure was provided. You want to talk about it when it's happening so that you can mitigate the problem. Communication, encouraging your operations team to communicate issues with finance teams as they hear them will also put your finance team in a better position and better poised to be able to tackle the issue earlier on. Let's move on to the next slide. So the last piece of this presentation, I wanted to focus on the level of care process and an attempt to give a general structure as to what a successful completion of a level of care process looks like and what that oversight process looks like, being that it's something that a lot of providers are challenged with. It's getting off the managed care topic and the staffing topic, but just talking process and structure and how much having a process that's documented can really help you on the finance side. So level of care is a tedious process, and it's often something that is overlooked. There's oftentimes a high ratio of denials that can lead to bad debt, right? If you don't get your level of care, it's going to be a challenge in payment, which nobody wants to deal with. So the first step is documenting the process of obtaining level of cares, right? What does that process look like for you as a company, and who is supposed to be doing that? Is it clear cut whether it should be your admissions person or your business office manager or your social worker or your MDS coordinator? Or is it, sometimes this person does it, sometimes that person does it? Understanding responsibilities and delegation of duties is really important and critical so that you can have a clear process that's being followed by one specific individual or one specific department. It's all in the details, right? Specific bullet list of steps necessary to complete. So what does the process look like, right? Sometimes you'll have a challenge that you're dealt with and you're saying, okay, what was the breakdown, right? The more detailed you can get with what your process is supposed to look like, the better poised you'll be when you look it over with your team and say, okay, we're in the process, we're along the process, did this break? And that's going to enable you to, as a leader, to solve the problem and try to mitigate it moving forward. Now, the process should include some sort of reporting from the clinical team to the finance and the billing team. So to ensure a second set of eyes, whether that is a daily, weekly, or monthly report or process. One of our key mottos as a company is that 2 eyes are always better than 1. And having accountability on the finance or billing team side, where there's accountability that's being provided to the person that needs to do the level of care process, can go a long way, right? This can be whether this topic or this concept, I think, applies to level of cares or really any other process. When there's somebody that needs to report to somebody else what they've done, that generates a lot of accountability and not only accountability, but it enforces a double check, right? If somebody's reporting to somebody else, they want to look through and make sure that they dotted all the I's and crossed all the T's. And let's face it, a lot of times things are omitted naturally because, humans make mistakes. But when you have an opportunity to look over what you've done, whether it's you before you report it to your counterpart or your counterpart that's reviewing it, collaboration can go a long way. And that's something that we definitely focus on a lot in our organization. The benefits of that are that the responsible parties will have an easy, documented step-by-step process, right? The more you as a leader can provide guidance in a documented process to your team about, okay, here's the cheat sheet on what you need to do to get that level of care, the more successful they'll be, because staff like direction and they like to be able to look at a bullet point of items and say, okay, here's step number 1, here's step number 2, here's step number 3. The second set of eyes ensures a seamless process between clinical to finance. So I think I spoke about the accountability side, but in addition to the accountability side, do the teams know about what's going on in the other department, right? If your finance team knows that a level of care was completed, okay, let me go and rebuild a claim. That's something that when there's communication, you can have swift turnaround time from bringing the payment to fruition. The last thing is that it's easy to zero in on a potential breakdown in the process for a plan of correction, right? Plan of corrections or POCs is something that I think is part and parcel in various different shapes and sizes when it comes to skilled nursing facility providers. And again, the more you can document what your process is, the more you can position yourself for a correction plan. So that really sums up our presentation for today. I thank you all for joining. Open to hearing any questions or comments in the chat section. And I hope you all enjoyed the presentation today. And thank you for joining.
Thank you so much, Israel. I appreciate it. Meredith, I'll let you wrap it up, Meredith. Didn't know if you were available.
Yes, good afternoon, everyone. Thank you so much, Israel, for the amazing presentation. Couldn't agree more with all these compounding factors that are impacting skilled nursing facilities and their staff and residents. We do not have any pressing questions in the chat, so we will conclude our webinar. And if folks want to get a hold of you, we will have your contact information available. Thank you so much.
Thank you.
And we do have one comment or question from Zelma Dean. Will this presentation be taped and available later? Yes, absolutely it will, and we'll send it out to attendees as well. Thank you so much. Have a great day, everyone.
Thank you, everybody.